Good afternoon. It's 1:02, so we'll get our meeting started. All of you received an email from Rose on the agenda for today, which is on the screen. And also, I want to call your attention. We have one board member online. I appreciate that. And then I'll start taking roll here shortly. Get our meeting started. I hope that both of you have had a good week so far, and good weekend. And I saw some people who we usually don't see in person, so welcome to those new guests. I'll start taking roll call, and we have the right sheet. So Vice Chair Andrea Lara.
Here.
Michelle.
Here.
Bill. Here. Sally.
Here.
Rick. Here. Bonnie.
Bonnie's gonna be late.
Awesome. Tony.
Bonnie's gonna be late.
Okay. Susan. She gonna be online, or do we know about Susan?
She probably won't be able to be.
Okay. And Misty.
I'm here, and Tony just texted he's on his way to the Salem convening, so.
Thank you. And then Robert.
Yes.
And I'm here, so we have Tony, Susan, and Bonnie. So we have 3 missing, so we're good to carry our meeting. All right. So did you all got to see the minutes from the previous meeting? Are there any questions or corrections that need to be made? All right. So without objection, we approve the minutes as presented. Here, no objections, so we adopted the minutes as presented. And I need a motion to adopt our agenda today with flexibility. A motion. Robert. Robert moved. Bill second. Would you like to switch your motion?
No.
All right, awesome. Well, without objection, do we adopt the agenda with flexibility of May 5th, 2026? Perfect. All right, so we will have our first business for the day today, and that is a public comment. And that's from Morgan Allen, Stacy, and OSBA.
Yeah.
Where do you like to? Sure, that's fine. Yeah,
Sure.
yes.
Thank you all. Michelson here on behalf of the Oregon School Boards Association. Appreciate the time and you all rearranging the agenda a bit to let us give public comment before the decision you're about to make today. We are here today to encourage the board to adopt scenario 2 for the rates for this coming year and the use of reserves. I want to share that for OSBA, that's not a recommendation that we come to lightly. We tend to operate in a space of being fairly conservative and long-term view when it comes to use of reserves and what that might be setting us up for in the future. But with the budget dynamic that so many of our districts are in this year and looking at the rates and the options before you, what that would mean at the local level, even at that $250 deductible and out-of-pocket max increase, right? That's coming on top of increases last year. Anything beyond the 500, as we indicated in the letter that we've submitted, really would be untenable for our districts. And so at that option to hit 250 with, investment still under what we had suggested in the letter, we would be comfortable with coming from reserves. Puts us in a space where that will offer a lot of relief, not only for our frontline workers, but one of our concerns is that if those rates go up for them out of pocket, it doesn't necessarily get built into a district's healthcare line item of their budget, but we are likely to face requests at the bargaining table, right, to make up for those increases in other areas that will then just, it'll be part of the district's budget, but it won't get factored into our current service level roll up in that way. It'll have a downstream impact that will continue to play out for years to come when we consider those total comp roll up costs. So that 250 feels like a reasonable ask on top of what we've already asked of staff. It's not lost on us that that's an across the board increase when we make those choices. So for some of our staff members, they may be better able to absorb increases of that nature. And for other of our staff members, represented by folks like my colleague sitting next to me, that amount hits a lot harder. And when that's coming on top of increases already built into their doctor's visits and things of that nature, right? That's real. And we recognize that that cost is real for many of our staff. So for that reason, that's why we're here to speak to that scenario too, and happy to partner with the board and other colleagues to try to find a better outcome in advance of the rate increases next year, both with the board and through potentially some legislative changes that we'd like to pursue. Thanks for letting us speak today.
Good afternoon, Mr. Chair. My name is Morgan Allen. I'm here on behalf of COSA, the Coalition of Oregon School Administrators. It's actually nice to see so many friendly folks. Stacy and I do a lot of testifying in work groups and legislative committees. So it's nice to have friendly people to talk to today. And I think I won't belabor everything that Stacy said, but I just do want to acknowledge that all the management associations and the labor associations were working collaboratively to try to provide the best healthcare to our members. And I think COSA and all of my colleagues in the other management labor association recognize that the primary challenge facing the board is the skyrocketing healthcare inflation and the 3.4% cap. And I think we're all committed to trying to talk to the governor and the legislature in 2027 about how to relieve that pressure for the board. Want to thank you, Mr. Chair, and the director for answering all of our questions and letting us come take a couple of minutes. As Stacy said, we're following up on the management letter, which included the community college folks as well, where we asked you to consider using up to $75 million in reserves. We were very happy to see the new board packet, which showed that there was additional savings that can drive that cost down quite significantly. And I think we are taking the unusual step of coming in person today to talk to you about adopting scenario 2, which we think provides a balance of using reserves wisely. I think it's about $64 million. But I think the other important thing that Stacy said is that keeps the deductibles and out of cost reasonable. And I think the other point I would add is even using that $64 million, that would still require our employees to absorb about $27 million in either direct cost increases or reduced services out of pocket and deductibles and everything. So about 30% of the total cost of getting you down to the 3.4% is still going to be borne by our K-12 employees. And as Stacy mentioned, I think and if you just pick up the paper, that school districts across Oregon are in fiscal crisis and eliminating hundreds of staff positions. And so, as Stacy mentioned, any cost savings and relief that you can provide directly through the use of reserves means that money doesn't become stuck in bargaining and allows us to better manage our budgets locally, ultimately likely saves jobs in some districts, which ultimately is what we're all here for, which is benefiting our students. So we thank you for your consideration again. For both COSA and OSBA, we're asking you to adopt scenario 2. We think that's the right balance between efficiencies and cost savings and use of reserves. And I think, again, I'll just close by saying we're very committed to talking to the governor and her team as associations, I think both labor and management, to try to deal with what is the real problem from our perspective, which is the 3.4% cap when you couple that with the rising inflation. So we appreciate a couple of moments. And again, we'd be happy to answer any questions.
All right, so we'll go to our next part of our agenda, and that is to renewal of responses and final benefit plan decisions, and that's attached in your email, and we'll see that on the screen. So with that, leave Kristen and John.
Thanks, Enrique. Rose, if you could go ahead to the Mercer presentation, please, on the agenda slide, that would be helpful. Thank you.
And this is an action item, just as a friendly reminder.
Good afternoon, members of the OEBB board. We are 1 month later than normal, so we're coming back together in May for the purpose of making a program and benefit decisions for all of our lines of coverage. So today we're going to recap the renewal as of May. So the overall renewal position is different, better when we came together in April. We're going to spend a little bit of time, just briefly, again, touching on trend, a little bit additional information this go around related to what's within our control and what's not. I know we've talked about this before. It's already come up today in light of the subsidy that we're thinking about spending this year. It's also necessary to continue thinking about next year also at the same time that we're thinking about this year, because we know that those 2 years are related. We have some strategies to talk through for achieving 3.4%. And then there are a handful of other things. They've not gotten as much airtime as the medical because they're not in the same state. They're important to round out OEB's overall package for 10-1. And so we'll spend some time on those: dental, vision, and life and disability with the standard. Rose, if you can go forward a slide, please. Actually, 2. Let's go to the timeline. There's one amendment to the timeline I'll call your attention to. So we are in the May 5th meeting. We're going to be making decisions today on benefits. We are not going to be able to vote on the final rate increase today because we'll actually need to know the outcome of today in order to go back to the carriers and say, okay, carriers, here's where we landed. What's the final renewal increase? So there will be a post step to this meeting that staff is going to help organize where we have the final, we don't need to vote on rates, so we'll have that final discussion increase in real financials land.
So does that mean that we're gonna have to call for a special meeting to finalize that?
Yeah, how are you thinking about that? I'll leave procedurally.
Yeah, I mean, it could be like a 5-10 minute phone kind of meeting.
Yeah, and just to clarify, everything that you're seeing today, their estimate, they'll be close. So the picture that we see when we come back together won't be dramatically different, just maybe we'll have an extra decimal. If we go forward one slide. So we've just been using this to keep ourselves organized because some of the benefits that you have, COBRA administration with VHS, the EAP through Canopy, and also Unum coverage, they are not up for renewal this year, so there's no decision to make about them. So we're focused on Kaiser, medical, dental, vision, MODA, same thing, Willamette Dental, VSP, and then also there's a standard renewal decision as well to make this year. All right, let's go forward 2 slides. Let's get to the important one. So with the updated round, now we're at 90.9 million, so better than we came together last month. Overall, the renewal increase, the composite PEPM renewal increase is 11.8. Obviously challenging considering our cap of 3.4% this year. Hence the need for some discussion around how to achieve. So where we're at with this final round is that the overall motor renewal is down a little bit to 14.8%. The overall Kaiser renewal is down a little bit as well to 3.1%. And then Willamette Dental and VSP. The Willamette Dental increase is reflecting the 3.4% for 3 years option. And then the VSP rate hold. So overall, we're at a blended increase of 11.8%. So we have 2 more slides. Rose, if you'll go forward 1 slide, please. You've seen these before, but just in light of the conversations we've been having over the last month, we just wanted to touch on them a little bit briefly. Because there's a notable difference between what's happening this year with MODA's renewal increase and Kaiser. And there was a difference last year and the prior 2 years also between Kaiser and MODA. And so we bring these slides forward just to highlight a couple of trends that we're seeing in the healthcare market. And I know we're feeling those together, right? That's why we're here. This is the Kaiser renewal increase going back to plan year 2020, 2021. We were helped out financially by the different dynamics during the pandemic for a while. And so we had a couple of years of low increases. And then beginning with the 22-23 plan year, it's really just been one thing after another, it feels like, as we've been attempting to get on top of that on behalf of our OEB members. This year, thankfully, the Kaiser renewal actually now with this round is a little bit under 3.4%, but came in initially right above. And we're at that target. But they had a difficult prior couple of years. And then if we go forward one slide. Sorry, let's see. Yeah, just to the MOTA, thank you. So during that same time period, for 2022 through 24-25, the MOTA renewal was actually pretty low, right around 3.4%. And then it wasn't until the 25-26 plan year that the MOTA renewal started to have a significant gap to 3.4%. This year, of course, really stands out. And I'm hoping and working hard to make sure that that's an anomaly. We're not facing that again.
So Kirsten, can I ask,
Yeah.
what's the possibility, not probability, I guess, of MOTA having the same type of bump and then going back down? Because I mean, we're talking about reserves, and so like that if it was possible that we're experiencing a bump that will self-correct like it did with Kaiser, I'd be more comfortable.
Yeah, so I think what's happening, so if you picture the Kaiser premium, we had a couple of years of like bigger increases, right? This increase is smaller, but it's not like we've come down to a level before those years of large increases. I think that, and I say that because I think what's happening with our healthcare ecosystem is we're now at a new higher level. But also there are other dynamics that are making trend higher than in previous years. So I don't think that hopefully, we're not going to have another increase this large. But maybe because of some of the factors that we've talked about so far this year, innovation, provider payment revenue, and some other factors, maybe trend will be higher. So in other words, we're at this new higher level. I don't think it's going to go up as much as this year, but it will go up, I think, still higher than in previous years. Yeah. Mercer's updated trend guidance is a base blended medical pharmacy trend of 9.9%. Now, we do have some factors that are unique to us with OEB. We have the CL committee, we have the innovation work group, who are helping to take on some additional detail behind the scenes, so we have better management. We also have Senate Bill 1067, which helps us a little bit with unit cost trend on some services. So there are some dynamics that should make us a little bit better than the 9.9% as a base starting increase. But still, that is a large amount away from 3.4%. Yeah. And let's talk about some of the trend drivers. Rose, if you go forward, please, to the OEB trend driver slide, I think in 2. And for those of you who were attending CIAO this morning or listening into CIAO, this topic essentially was highlighted all throughout the CIAO meeting this morning, which is the balance we try to strike with innovative treatment therapies that are clinically beneficial and also expensive. And so we struggle between doing what's right for our members and being able to afford premium and have low copays, and doing what's right for our members in terms of making new clinically effective care accessible. So it's a hard thing that we're trying to do all at one time. I think innovation really is the star of the show when it comes to high medical trends. And we talked about provider revenue and the role of technology also in revenue changes as well. So let's see, we've talked about cost increases, unit cost increases, billing practice changes, volume increases, pharmacy trend being driven by innovation, more expensive drugs being taken by more people. And then unit cost management strategies are needed, but not enough alone to manage medical trend. And that really is a call out to Senate Bill 1067, which has been tremendously helpful. Without Senate Bill 1067, our annual expenditures for OEB might be 60 million more than they are per year. So by having Senate Bill 1067 in place, the amount we're paying on average, we're saving so much money every year. But in terms of the year-over-year increase, there are just factors outside of our control. Innovation being one, the number of services patients seek being another. that are overshadowing the trend benefit for Senate Bill 1067. Let's go forward to the next slide. So we wanted to include some food for thought for a couple of reasons. I think when we talk about trends like we've experienced this last year, it's been really frustrating, I think, and maybe we collectively feel helpless around what can we do? How about, that all of the things that we've been doing, why aren't they making more of a difference? And this slide is to really highlight, yes, there are a large number of things that are not within our control. But there are still things that are within our control. And as we immediately make decisions for next plan year, we are also thinking ahead to 10/1/27. And so this is the area of things within the controllable side of the slide, the set of things that we'll be thinking about together. Preventive care and wellness, site of care, a lot of these, they're not new. Pharmacy management, technology and delivery models, provider and vendor contracting. That will be a focus for next year as well as we try to think about how to double down on this idea that some providers can be equally effective and also cost less. Benefit design and member engagement. So there is still a lot. Hi, Tony. A lot within our control, and we'll start talking about that as soon as we get underway. Next plan you're thinking ahead. Hi. So that wraps it up for the context part of the presentation. So to summarize where we're at, we have a $90.9 million gap, better than last month by about 15 million. Makes the conversation a little bit easier, still not pleasant, not quite as painful. Any questions or comments about this context before we move into the strategies section with one brief clinical detour before we jump right into the strategies? Dr. Latta.
Really, for me, it's just what exactly do you mean when you say double down? What is that in plain language?
So, for example, for 10/1/25, think about what year we're talking about. For October 1st, 2025, we put Garner in place. And Garner is a tool. It's an app essentially, although you can also call a concierge service that connects members with providers who meet two criteria. They are high quality providers, and also within the universe of high quality providers, they are the ones that are lower cost. And so Garner is a tool to survey the landscape of providers. And then we for providers who meet that criteria, we call them efficient. And Garner will steer members to the more efficient providers. So that idea right now is being implemented to OEBB members on a voluntary basis through the app. With a measure of success. We have the latest Garner engagement statistics. So we know that members are using Garner. We also know there's an opportunity to improve outreach and engagement and help educate everybody about the priority niche for Garner. But there are other ways to accomplish that as well. So for example, it might be asking MODA within your main provider network, let's identify some outliers in terms of contracting or price. Maybe these providers aren't serving our overall goals for OEBB. So in that case, that would be a more custom MODA approach. So that's what I mean by focusing more on efficiency initiatives.
We're talking about invest more money,
The idea would be to save money.
even if you're increasing outreach providers, maybe.
Think of it this way. If there's the universe of providers in MODA's Connexus network, there are providers within that network that are different levels of quality, right? Some are better than others, as measured by their complication rate and other metrics. Some are more expensive than others. We can see that in the associated contracted rates. So it doesn't cost any money to say hey, so-and-so provider, you are an outlier, you're really expensive. This coming year, we're gonna be, I don't know, more strict with negotiating. Take our lower rate request or you're out. That doesn't cost the plan any more money. The idea is that if you take away the choice of the more expensive provider, as long as you have enough choice left over, and we're very careful about that, then members go to the lower cost providers. We've saved money. So clarifying.
Right now, yeah. Let me process that.
Yeah, sure. You can always ask again too. If you have another follow-up question.
I was wondering if those conversations happen, so that's good information. The higher cost providers.
Yeah, and I know that Craig Anderson is here as well. He's the senior vice president too at MODA and has a lot of insight into contracting. And contracting is something that we've talked a lot about. The trade-off with contracting is access. And so it's easy to say, like, just be tougher at negotiation. But that's sort of a collective decision, right? That you guys actually have to make. You have to decide your tolerance for keeping certain people in and having certain other people out. And that's much trickier. I feel like that's a much harder thing when you actually see, who it is and where they are and what services they are and how many members go to them. Then it's hard to think about, limiting access to certain providers, but that's definitely something that we'll come back to next year. And it also doesn't have to be all or nothing. We can take an approach of for certain providers might be lower cost than others. So there's lots of ways to do that. But that idea of efficiency is something that all employers are looking at because the cost increases are untenable for everyone.
Everybody has to make money. I'm sure it's a delicate balancing act of having those conversations and not limiting care and you're out of our network.
Yeah. Michelle?
So I know insurance companies have overhead administrative costs, and so do all the providers. Do you have a sense of like how much that impacts the overall cost of our insurance, and also if those costs are rising along with all of these things that you're showing us here at the same rate? Like, are there overhead and administrative costs increasing by 17%?
Yeah, so when we were initially preparing, I think the first time that you saw the trend presentation in its more robust form, so maybe that was February. In preparation for that, we did educate ourselves about the provider perspective on trend. And what providers will tell you is that, yes, their overhead has been increasing more in line with inflation. And that's because the things that they're doing, they need to go to the bank and take out a loan because they need to make capital improvements, or they need to buy supplies, or a big one for providers has been wages and wage pressure. We've read a lot about that in Oregon, especially post-pandemic. So providers would tell you that they're under huge amounts of financial strain. And part of that is higher overhead costs because of general economic conditions.
Questions?
All right, so if we go forward a couple of slides, Rose, to the one that says cardiometabolic program decisions. So we have a whole CIAL committee that meets monthly. And the role of the CIAL committee is to evaluate OEBB's clinical programs. We look for gaps in care and then we recommend solutions. We also look at current programs in force and recommend them for renewal or not. So your CIAL committee went through this process this last year and looked at a subset of your program partners who deal in the cardiometabolic space. So just running down the list to refresh everybody's memory. So Livongo is a type 2 diabetes, essentially a digital self-management tool with some supplies available through MODA. Virta is a type 2 diabetes reversal program through MODA. Omada, both the weight management program and the type 2 diabetes prevention program are available through Kaiser. MODA has a standalone 3D program as well, and then Weight Watchers is available to both. So that's the spectrum of cardiometabolic programs. We have a lot of programs because it's been a condition of focus for the last few years, impacting a lot of members. So your CIAL committee went through an evaluation of the engagement, the effectiveness, And the result of that was to recommend that the program Livongo not be renewed for next year. And then the recommendation would be for all of the other programs to renew. And that's just because the outcomes there just were not compelling. And there was a little bit of savings. We'll see that later. But the reason we're starting with these decisions is because they impact, these are currently getting funded with reserves this year. And they impact the amount of reserves available for everything else we're going to talk about today by a little bit. So we thought we would start by this, and then we can move on with the rest of them. Yeah, Sally.
For the members that are accessing the resources through Livongo, are there the same resources through like Berta or the pre-D? Or I'm just wondering, what are our members that are accessing those resources losing?
I think just the digital, probably just the digital alert system, because they can get test strips through the normal plan benefit.
Yeah, I'm sorry, I missed the question.
Oh, Sally was just wondering for members who are currently on Livongo, and if they were to lose Livongo, what functionality would they be losing out that couldn't be replaced with something else?
Yeah, and so you're right. So right now through Livongo, they get free test strips and testing supplies shipped to their door. And then they do have the platform where they can engage with a health coach, and then they get their readings. So if their readings are off, it creates an alert. So removing Livongo, they will be moving to getting their testing supplies through their medical benefit instead. And then they don't have that alert thing anymore, that whole program and access to the health coach. But they do have access to MODA health coaches, and we do have diabetes program and health coaches who do work with diabetic members.
So they're getting free test strips through Livongo. Do they get free test strips through IDEA? Okay.
Erica, to clarify, these programs are being funded by reserves, you said?
Yes.
Through OEBB reserves?
Yes. Yeah, and if we want to, we could go forward one slide, Rose. So in the scenarios that were prepared, we've assumed $15.7 million in MODA RSR. There's $3 million available in Kaiser. And then that's less. We've budgeted already continuing to fund those programs out of reserves for the 26-27 plan year. And so you can see for Kaiser, the total is about $300,000 a year. And then for MODA, $1.3 million a year total. So Rose, if you can back up a slide, thank you. I think the idea, if you were, yeah, go ahead.
I just have another question. If there are members that are accessing that benefit where no longer receiving those test strips would impose like a really difficult financial hardship, are there any other, there's no other resources? And do you know how many members access that? Like,
Yeah, I know we said that. I don't know it off the top of my head, but Alina, if you can hear me, if you can pull up that number and put it in chat, that would be great.
And it was one later in the deck on slide 38, but it's 796 members.
And I will just say too, Livongo is one of the programs that we at MODA are evaluating on the effectiveness and have found it to be not one of our most effective programs. So to say we do the recommendations.
So what is gonna be the final destination for those members? I'm asking just for quality of care and continuity of care for those members and patients. Do we have a plan for that? They are gonna transition to another one? You know that?
Yeah, the normal process when we discontinue a program is, I'm sure we have a whole discontinuation plan, educate our members, but I'll ask Erica to speak to that.
Yeah, we would work with OEBB to determine the communication plan, and OEBB would review any materials that we sent out, but we would plan on sending a communication that explained the program going away, and then also provided additional resources that members could use to move to, including like health coaching and stuff like that.
So how many months ahead are we planning this? Because if we already have that, it's gonna be discontinued. Do we have a plan in place?
No plan in place
Okay.
because the decision at made, but as soon as the decision is made, if it is made to discontinue, we would start working on the plans, the communication plan right away. So we can pull together a communication plan pretty quickly and get it out with quite a bit of notice.
The effective starts on October 1. That's when it's, a year starts October 1. So if we make the decision in 2 weeks, then they have from now till October 1.
Those letters, they can come next week if we make the decision today.
I don't think we can turn it around in a week, but we can definitely turn it around quickly.
What is the time frame?
Well, I think we could probably pull together an initial communication in a couple of weeks, and then we would allow, I don't know how long you guys think.
Yeah, I mean, we can usually review things pretty quickly. I mean, our communications team tries to stay up.
Yeah, I need like a 3 weeks, 2 weeks,
Yeah.
a month.
Absolutely, yeah.
Okay.
So on that note, I know last year we had a similar program that we discontinued. And you send that email to the board members, hey, this is the email was sent to the members who were impacted. It was not a large number of members. So it will be helpful if you can send that email that you sent to the members. So we are aware that is going out, but 700 compared to the 40,000+ people that we have. It's a small fraction, but we all know that if there's a small error, then the entire system gets criticized, and we don't want that too. But I really appreciate your Vice Chair being persistent on timeline for us to get a communication message. And we all know the summer for a lot of our members, they stop checking emails. So I really appreciate if we can develop a campaign for September, right? Because October comes up around the corner, and that's around sign up time. So Kamota can work on that, whatever decision is decided.
And we can do 2 communications too, if that's helpful. We can do one and get it out before the school season ends, the school year ends, because we are very aware that a lot of OM members don't check their emails during the summertime. And then we can have another one go out in September too.
And you're gonna have a hotline just in case I have questions about it, or is there
We have our health navigators, and so what we would do is we would communicate to our health navigators. We have specific OEB training for our health navigators, and then we also just do updates all the time to them. And so they would have information, so when members are calling, they would be able to respond to the members, help them answer their questions, and then also direct them to other resources that might be a good fit for them.
answer your question?
Yeah, and then the capacity for welcome these new members, just because it's just like not say like, oh, we don't have the service anymore, and then we don't even have providers capacity or I don't know, material to share with them. So do we have that in plan or no? Like, because you are gonna discontinue this program, what is gonna happen with them?
Yeah.
Do we have that?
So what would happen with them is in that email communication, we can direct them to reach out to their primary care provider. That's where we would want them to go so that they can talk about it with their PCP, and then they can develop a plan with their PCP.
Okay, so that's not really good practice because you are relying on, you are cutting the service and then you rely on them that they find that. It's gonna take a lot because healthcare is changing a lot, right? So to see a PCP takes months, like with private insurance, right? So for me, it takes like 6 weeks. So if you are sending the letter in September, the continuum of care is going to be really impacted there.
We would be sending a letter both right now to get it out, and then also in September, because some members might actually join between now and September too. So we want to pick up any new members that might have joined the program. We would stop sending communications about the program if the board voted to discontinue it. So it would, and we can even remove it like from our dashboard and stuff so that we try not to get more members in there. But if Dr. Popovich is on the phone too, feel free to jump in here. But that kind of thing, while an appointment with your PCP would be good, members can also do communications with their primary care providers about that as well. And the switch really for the members is the testing supplies getting delivered. So that's going to be the switch that they're going to need to make, that our transition team would be really working with to get them to go from having them delivered through Livongo to getting them through their prescription benefit.
And you have enough capacity to process those 700 people. Yes?
Yes. Okay. Yeah, and as Enrique said, we've had transitions that involve way more than 780 people or whatever that was. So yeah, I'm confident that we can help manage those numbers to getting them connected to what they need to get connected to. Yeah.
And would those members be automatically moved to the Verta program or offered the Verta program?
No, they wouldn't. Verta is a very different program than Livongo, which is why we see different results from it. It is a program that the members have to be highly motivated in order to really get anything out of. So it's not just assumed that someone should go into Verta. We will absolutely be listing it as an option for members when we send out the communication. And it will also be something that shows up like in their dashboard and that our navigators are recommending to members. But I wouldn't expect all members to just go right into Verta.
It's like Livongo is supplies, right? Kind of health coaching, maintenance. And Verta is reversal and weight loss, those kinds of things. Is
Yeah,
that
the way I always think of it is Livongo, the purpose is to help members be the best type 2 diabetic they can be.
Yeah.
And Verta is to help members reverse type 2 diabetes. So it's management versus reversal for those two programs.
So do you want to save until the end, a vote on everything or take it into the meeting as we go? Get a question.
I guess I'll put the question to thumbs up if we take the vote now on this, or we can take so give me your thumbs up if you're gonna vote on this action item now. 1, 2, 3, 4, 5. Vote out if you wanna take this vote at the end. 2. And so you kind of like, 1 to 1, 2 there. I guess since we have a tie, kind of, we'll just vote now, since the information is fresh in our mind and we had a discussion. So if anyone wants to make a motion to move so we can continue the discussion. Yeah, go ahead.
So is the reluctance for those who don't, because you want to see all the information and see if this affects anything else, is that the key?
what would we
Because
have?
I'm okay
to
with just
change?
going through 5 votes at the
Yeah.
end,
Yeah.
but if you want to see, because I kind of know that because I'm on CAL. So I know that this was recommended by CAL because of its ineffectiveness of the program. It wasn't about cost savings, but just this inability to actually make healthy people. Right. So, but we can roll through all these at the end too. I'm good either way, I guess, is that because, so I kind of vote now because I kind of did this with CL. So, but if you're uncomfortable with that, I'm also good with saying, let's just roll 5 votes at the end.
Yeah, because I'm just curious, like what other changes would have to be made if we.
That's
do
what I'm saying.
that?
If
And
you're concerned,
keep in
then
mind, like I understand
change.
maybe the health outcomes aren't the same as the other ones, but when I'm sitting here representing the classified group and we know that the average income is $35,000 a year, like taking away benefit like that can cause some management issues, right? If we're too.
So based on
success.
you guys being uncomfortable with knowing all the things coming along, I'll split my vote and say, let's just do 5 votes at the end for the comfort of that.
And Dr. Letta, for those of you who were in the CL meeting earlier, feel free to chime in and provide context on some of the recommendations if you need to from your board perspective. All right, so we'll just take the votes at the end and so go to the next action item.
Yeah, that's great. So we can go forward 2 slides, Rose. It's called efficiency package. So this is exactly the same as you saw last month with 2 changes. So you'll see in row 6, the addition of the Livongo program. So that program was recommended for termination by CO, as Bill said, because it wasn't improving health outcomes. From a financial perspective, there's a savings because it's $80 per participant per month. So it is not insignificant when we think about the cost of programs. The other change that is different from what you saw last month, and this was based on feedback, is that in item number 3, the office visit copay. So this item was 2 things. We were increasing the incentive care and the virtual care office visit provider copay to match the office visit copay, and then taking everything up by a dollar amount. Last month it was 5. this month, we, in an effort to get some additional money to help close the gap, to take pressure off benefits and subsidy, based on feedback, we thought there was a little room there to make that 10 instead of 5. And so with these 6 changes, the total package is worth 15.4 million. So as you think about what you want to do with Livongo and the trade-offs there, the trade-off would be assuming, you know, the benefit options are what they are. The trade-off is really about 700,000 in subsidy to continue that program or not. And then if we go forward 1 slide, we'll roll it all together. So I'll walk you through first what you're looking at. We'll go from top to bottom. So we're starting with the projected gap to 3.4% of 90.9 million. That's the overall gap between our current renewal increase and gives 11.8 and 3.4%. So we're at 90.9. Assuming that the board approves the efficiency package, that was 15.4 million. That takes our gap down to 75.5 million. And then how we get the gap closed from there is just a combination of subsidy plus benefit change. And so scenarios 1 through 5 vary that amount. So in the lower numbered scenarios, we're using more subsidy, less benefit change. And then as we go to scenarios 3, 4, and 5, we're using less subsidy and making up more of the gap with benefit change. So we have 5 options there. Scenario 1 actually is a no deductible out-of-pocket increase. And so we would be funding the entire 75.6 million, just a tiny bit of rounding, $75.6 million gap with subsidy. And then there's a little bit more information at the bottom of that column. So I'll tell you about what that means. If we say, for example, in scenario 1, make efficiency plan changes worth 15.4 million, make up the rest of the difference with by spending 75.6 million of our subsidy. That means we have 18.7 million in subsidy left over. And then we know there's a compounding effect from spending subsidy this year on next year. So if we think about a base trend plus that subsidy difference, that would mean next year maybe we would be facing an 18.8% increase. In scenario 2, it will start to take a little pressure off the subsidy now. And so now we're saying with scenario 2, okay, what if we made a $250 deductible out-of-pocket increase? Well, now I need to only spend 64 million in reserve. So I've saved about 15 million in reserve for next year. And maybe so that leaves 30 million in reserve for next year, and it will earn interest over the year. So that's definitely a factor here too. And then next year, we might expect a slightly lower renewal increase of 17.4%. I want to pause and talk about Garner for a minute. So we know that there are pros and cons. Because of the financial incentive to use Garner, it's tied to the amount of your deductible. Because Garner reimburses you your out-of-pocket expenses. So when we increase the deductible, we increase your out-of-pocket expenses, which makes you think, is there a way I can offset that? Oh, I remember I could go to Garner. So we know that Garner does not have every provider in every area. So that is 100% a con in the con column. However, where Garner shines is in the expensive procedures, the outpatient surgery, the inpatient surgery. That's where you're going to actually eat into your deductible and coinsurance. For those situations, we do know, because we looked at data, that some individuals in rural areas were already traveling to areas where there are Garner providers available for those services. And so there is, if we think about the role of Garner in helping offset some of this benefit change, there is still benefit even in rural Oregon, if we think about the offset to, say, expensive procedure costs. And I say that because in any of these benefit change options, the 250, 500, 750, or 1,000, we can increase the Garner reimbursement by the same amount. So it does not offset the benefit change philosophically or emotionally for members. But for some members, it actually will financially offset benefit change. So scenario 2, the $250 deductible option saves 11 million, and then essentially every option shifts 10 million, the subsidy bucket to the benefit change bucket.
Interesting. Okay, just interject one thought, on the subsidy fund balance line, just a note, when OEB collects premiums each month, we actually make quite a bit of money in interest earnings by holding those monies before reimbursing ODA or passing it through to Kaiser. And then with the amount of subsidy left, we would continue earning interest earnings on those reserves throughout the year. So those numbers would be more than what you see on that line there. For the following year. A few $1 million, yeah.
What'd you say?
Just by a few $1 million, yeah.
Are members using Garner?
Yes, they are. I don't want to put John on the spot, but I'm wondering if you, because I don't have the statistic in mind, but I know John is a little closer to it. We do have the most recent Garner engagement data.
Yeah, I mean, and
Or Margaret, yeah.
sent out something yesterday.
Yeah, I did. So, yeah,
Because it is about almost 28% now. Is registered.
yeah, based on our most recent conversation with Garner late last week, 27.2% of the eligible to participate population had registered on Garner and created an account. That was as of April 30th. They are undertaking some additional outreach efforts in the next couple of months to try to drive that number even higher. So we're getting close to 30% have signed up. Of the members who have signed up, 50% have received care from a Garner top provider at least once, and 41% have received a reimbursement. And so, and the reason that's not the full 50% is because, well, first of all, reimbursements have to process. There's a period of time before those go out. And then also members who are in a plan, an HSA plan, have to meet that minimum deductible before the Garner reimbursement kicks in. So there's a little bit of a difference in terms of the number who have received care versus the percentage who have gotten reimbursements as of yet. But that 41% of members that have received reimbursement, that equates to about 10% of all OEB members who could participate in Garner. So continuing to do some outreach initiatives over the next couple months to drive up those engagement numbers. The average reimbursement amount, and this number I'm quoting, is as of the close of the second quarter, which would have been for the OEB plan year, would have been end of March. But the average reimbursement amount was running at about $463 for the members that had received reimbursement.
And I think the other interesting statistic was how many members actually have already maxed out the incentive too. I thought that was an interesting.
Yeah, and we do. I'll keep scrolling and find that one because I know
it was a good number, like several hundred of them.
One follow-up question. So I would love to encourage our members to sign up, and once I do that, I'm going to get a lot of questions from them. One of the questions I'm sure will be, what if I'm referred to a provider who's not approved Garner provider? Because those are the scenarios that, if you have to see a certain specialist, you don't have a lot of control over who you're referred to. And then once you get the referral, what's the practical, can a patient ask to switch to another provider in the practice once they have the referral? Maybe that's too, in the weeds for this group, but I'm just thinking of questions our members would have.
Yeah, it's a good question, Michelle.
So you're saying if the PCP refers you to a certain specialist and it's not a Garner specialist?
So many specialists are just months long waiting list, and you really have to take the first person. You have, yeah.
I think ideally we would encourage members to use the Garner app, find a specialist on the Garner app that is in that area, their condition, what they need treatment for, and then request a referral to that provider.
And then Gartner also is checking to make sure that they're referring you to a specialist that has availability as well.
Okay.
So I think that's the added plus. But understand that there's, from the member perspective, it's like, oh, my PCP is telling me one thing, you're telling me another thing. I think the other thing too, though, that this is really where Garner does, and Kirsten was talking about this earlier too, this is really the value of Garner is referring you to specialty. That's where it can really happen.
If a provider is not covered, is not a Garner approved provider, is it because they've been vetted and rejected or because they just haven't, no one's asked yet? Like, can a patient ask for them to be vetted?
I think for the most part, they probably have been, yeah.
Thank you.
Yeah, I'm wondering if, like, the whole idea of Garner was to create savings, right? But we're still seeing a huge increase. So clearly we need to get Garner utilization up to get those savings for MODA, correct? We at 4J decided to host a Garner enrollment help session where we'll have laptops available and all that sort of stuff. I reached out to Garner to see if they would be willing to come in person and do a presentation, help our employees, and they said that they would only come if we could guarantee that 100 of our members would show up. And that's a really difficult thing to do, right? And so, you know, I was like, I can try, but I can't guarantee that. Thankfully, MODA said they would come down and help with that, which is great. But I'm wondering if like we can kind of push that a little bit for Garner to be a little bit more willing to be more interactive in those ways with our districts to get that membership up, or to get that utilization rate up, right? Like we need them to work with us, to work with our members to make all of that kind of hit that threshold that we need for those savings. So maybe next year we're not exact same boat with MODA. So I'm not sure like what we can do on our end to be like, can you be a little bit more flexible? Like I said, MODA stepped up and they're gonna come for our enrollment session. However, it would be really nice if Garner would be willing to do the same thing.
That's great that you're doing that. And
Yeah.
I think, right now with Georgianne, we're trying to think of any way we can to get more Garner enrollments and hitting every corner of OEB we can. So, yeah, we'll definitely push them to engage.
Okay.
And just to respond to, Garner has come to a lot of meetings and mostly around open enrollment. And we try and like pick the ones that make the most sense for the and for my team, we will always say yes to any meeting that anybody wants and we'll be there to help. And my team can also answer the majority of the questions about Garner and walk people through the app. So we are always there to support and we will also help, like if there's an event that it makes Garner should be there, we will absolutely push on Garner to be, but they have been, for the most part, I mean, during open enrollment, they came to some meetings where there were only a few people, right? You know? So, but we are absolutely there to help support Garner and just all of it needs, so just reach out. We will be sending out emails, around open enrollment, people for the open enrollment fairs, but we will go anytime of year too.
And we'll give you guys props for showing up anytime we've asked, really. So we've asked a lot over this last year, so appreciate it.
So another alternative in this conversation that may or may not be successful, but at least it can be investigated, is once we're done with this and we can immediately start working on that's for next year and talk to MODA about ways to alter their plans to incent Garner more.
Yeah. Mm-hmm.
And that's possible.
Yeah. Okay. Yeah. Thank you.
Go ahead. Question.
Just to preface this, if my question belongs outside of this particular process, because I'm still a learner, please redirect. But am I understanding that whether it's Garner or the conversation earlier around incentivizing lower costs, it's just procedures put in place to incentivize lower costs, that in this case, if a member receives care from a provider that's identified to be that provider, that provider is actually offering and providing the service at a cost lower than the negotiated rate that they established at the outset of the benefit year?
It's not quite that they're offering a rate that's below what's negotiated is that their negotiated rate is lower than other providers' negotiated rates.
That's helpful. And your practice patterns, I think, is the other.
Yeah, and
piece.
other things.
Outcomes and how they refer. It's really looking at each provider holistically.
It makes perfect sense, both the outcomes and what I'm hearing is
And how they're prescribing.
the difference is not providing the service at a lower rate than what was negotiated. It's negotiating a lower rate.
Yeah, and referring to specialists who are also lower cost and being more judicious with the subscription. And John mentioned I think Garner looks at like 500 metrics. Remembering, we did the deep dive like a year ago, so it's been a long time, but they have 75% of the national healthcare data, and their algorithm takes into account 500 different provider quality metrics all around this thing loosely called provider practice patterns to arrive at and then they rank everybody and offer you the top 20%.
Thanks for remediating for me.
Yeah, no worries. Yeah, so much to keep track of.
Yeah, I've got several questions. I'm sorry, I'm a newbie and I have some questions are just on terminology, I guess. On the renewal option, on this spreadsheet here, when we look at the last line, the estimated 27-28 increase, base plus subsidy, is that before we apply the 3.4% allowed rate increase?
Right. So 18.8 minus 3.4 would be a 15.4% gap.
Okay, I wanted to clarify that. When we talk about increasing the out-of-pocket, and then your slide a little later, the deductible by 500 and the out-of-pocket by 500 as well, what happens to the family maximum? Does it stay the same?
The multiplier stays the same.
I don't know what that means.
Yeah, so last year, yes, I'm sorry about that. That was tech lingo. Last year, we made a small enhancement, meaningful if you had a family, but we made an enhancement last year, 10/1/25 for Kaiser and Moda actually, to make all of the family accumulators 2 times the individual accumulators. Accumulators meaning deductible and out-of-pocket maximum. And so when we take up the individual deductible by 500, we're going to take the family deductible up by 1,000 because that's that 2 times the individual. That's what I mean by multiplier. And that's the same for all plans and actually now for both carriers as well.
I'm struggling with math. Medical plan 1, MODA, in-network coordinated care, maximum out-of-pocket per member, $3,750. Maximum out-of-pocket per family, $8,300.
We have a slide, Rick. Let me take us there. It will be easier to see. Let's go to, the math will be the easiest, but we don't have family on it.
Yeah, but it might be easy just to go to the next slide and then you can see it and then just talk about the math.
Yeah, we can. Rose, if you want to go forward to the next slide. This is just the individual though. It's the individual in the CCM tier. This is the $250 option.
Right.
Yeah. So the family deductible would go from $1,400 to $1,900, which is $950 times 2.
Oh, I'm not even seeing the numbers you're talking about.
Yeah, no worries, Rick. So let me just tell you how this slide is laid out. So the first 2 columns are the current deductible, individual CCM deductible by plan, plans 1 through 5. And then the second column is under this scenario where we add 250 to it. What would the new deductible be?
Got it.
Yeah, so the current individual deductible for plan 1, $700.
Yeah.
If we make scenario 2, if the board approves scenario 2, the new individual deductible would be $950.
Get that.
Yeah. What's being added to the family is 2 times what's being added to the individual. So we'd be adding $500 to the family deductible, and out-of-pocket maximum is another way to say what I was saying. That's helpful.
So that's going to go to 8,800. You're looking at the individual out-of-pocket. I'm talking about the family max.
Exactly. Mm-hmm.
So in a simple,
2 times 250 is 500. 500 plus 8,300 is 8,800.
Yeah. Trying to think if we can pull up the side-by-side benefit comparison. We could do that quickly, maybe, for you guys to look at together, if that'd be helpful.
I'm just trying to,
I appreciate your question. It's important. Yeah, give me 1 second. I think what we can do is, OEB has an excellent website that has all of this listed, and also MODA has them side by side as well.
So while you do that, I'll have an announcement, and then I will give you some time to get ready for that.
Just that Bonnie emailed around one thing. She's okay, but she's waiting for a tow.
Then, if you need 5 minutes, Kristen, we can definitely take a break right now.
Let's do that, Enrique. That'd be good, because I still need to give Rose a link to pull out
Perfect.
too.
So we'll do it's at 2:07. Let's get back around 2:14, just some extra minutes. Well, I think it's an important conversation because the question is gonna be, what's my family deductible? What's my family? And I wanna make sure you feel confident in voting on when you go back to our constituents for individual and for family. So I think the wait is worth having. So, Susan?
Take your. I made your question. Something like that.
Get your question. I've been gone. I just go.
well, see, I never knew how they arrived at the family max.
Yeah.
Yeah, CCM and anchor to the non-CCM, so I think.
How are you doing here, Sally?
Just
Just fine and dandy. All decisions ahead of you.
Oh, thank you. Muted now. Okay, Enrique, sorry, we were on mute before. Do you want to try that again?
Yes, Kristen. So we're back in business. We will review the individual deductible and the family deductible and the multiplier as is known technically. So we'll get started.
You all know a new word. Now you can talk that at home tonight. Rose, if you're able to share, I emailed you a link to the online benefit comparison. I don't know if you're able to switch from Teams to the benefit comparison. It'd be helpful. So we'll look at the side-by-side benefit comparison because there's a nuance coming into play. It's probably old perfect. Rose, if you'll scroll down, please, to the MODA page where it says medical plans 1, 2, and 3. Perfect, thank you. So on our slide, yeah, that's perfect, Rose. Thank you so much. Yeah, perfect. What we showed on our slide is from the very first column, medical plan 1, it's the in-network coordinated care. Currently 700 would go to 950. The out-of-pocket currently 3750 would go to 4,000, right? But I was reminded that our family accumulators are based on the non-CCM tier, the middle tier, and that's because of a programming technical consideration. So what's actually going to happen is that the non-coordinated care, the middle tier, is also going to go up 250 for the individual. So it'll go from 800 to 1050. And then the maximum deductible per family would go from 1,600 to 2,100 because that's 2 times the 250. And then it's going to like complete a circle, Rick. So it's going to go from 800 to 1,600. This will turn into 2,100. And that makes the CCM family 2,100 also, because you'll notice that the CCM and the non-CCM maximum deductible per family are the same. They have to be the same for it to programmatically work. Does that make sense? You're following?
Okay. So I'm focused on the 8,300 on the last line in that top section.
Yeah, so the 8,300 is going to go to 8,800 because we're going to add 500 to it, which is.
That's what I was asking before the break.
Yeah. And then the 8,800 is going to also be the out-of-pocket maximum per family for the CCM tier as well. Yeah.
And then I just had my last question.
No, it's good. Thank you.
Just if I'm, as a layperson, trying to do just a rough estimate of what rates would actually look like, and I tried to apply 3.4% to the current year premium, would I be in the ballpark of what premiums might look like next year? Or would that be an error in judgment of that? That's not the way that it's done at all.
So we were just talking about this on break, because if we're making a $250 deductible increase to each of the plans, that is a more meaningful increase. This happened to us last year with Kaiser. It's a more meaningful increase to plan 1 because $250 on top of 700 is a bigger change than if we were to zoom over to the $2,300 deductible plan and add 250 to it. That's a less meaningful. I don't mean emotionally meaningful. I mean financially impactful.
Percentage-wise, it's less.
Percentage-wise, yes. Yeah, exactly. Yeah, so there's a little bit of a variation there.
Okay, but my question is I'm talking about the monthly premium. If I take single person on plan 1, 820, 157, and I multiplied 103.4, would that be in the ballpark for next year's premium or don't rely on that? That's not the way it's done.
So that's not technically going to be the answer because of the reason I just said, which is that the $250 deductible is a bigger increase to plan, bigger offset to plan 1 than plan 7. I don't know if we got that far actually with Moda about how to implement. We've been so focused on the strategies. Let us think about that for a second, Rick. I totally understand your question.
I mean, I'm just kind of thinking about where the rubber meets the road, right? It's what the member's gonna see is, okay, this is how much of my health insurance benefit or my paycheck it chews up.
Yeah, no, 100%. I'm just thinking if there's anything that we have to reference quickly about the range of rate increases if we were to do it that way. I know.
This is what we would get on a week from now.
Yes.
And we would get these actual, the rate table.
Yes, that's the part. Yes, that was kind of the caveat to coming back and showing you how it all.
I'm jumping the gun then. That's okay.
Yeah. The renewal increase, if I understood this correctly, the renewal increase does get applied evenly across all plans.
You guys are thinking about applying it evenly, even though the benefit change is not worth the same per plan.
Yes, and, yes, that's what we normally do, and we can do it differently.
Yeah.
But normally it's that we apply whatever increase it comes out to evenly across the plans, even though every year the plans don't increase at the same rate. And the benefit changes do impact the plans differently. We always do just take up the plans the same, except for those years where we then go through and adjust the relativities.
Yeah.
And then the adjustment of the relativity is something that usually gets presented to the board, and then goes through that process. I don't think we've done it since Mercer's been on. Yeah, but the relativities are off, and it's a great question, because it's very valid.
So if they're applied evenly, you would not need that second board meeting. I mean, you could just make that as part of the motion today. Whatever decision, and with the expectation that the rates would be driven.
But it might be helpful to actually see the rate table.
Yeah. Well, you'll see them, yeah, no matter what, but yeah, it's up to the board.
Understood. Thank you. That was my questions. I appreciate
You're good. They're technical.
Oh, good.
Just maybe a follow-up clarification. Thank you. Am I hearing, Ali, you right, that the backroom work hasn't been done, that a motion could be made to have a plan, or excuse me, a solution scenario, whatever, move forward with the expectation or request that a sliding scale be be how that increase is approached as opposed to the flat 250 across. Is that?
Yeah, sort of. If the motion was to say, option 1, 2, 3, 4, whatever, and then the rates would be applied evenly across the plans. Because if they weren't applied evenly, then you'd come back in a week and see, or is the board okay with how that distribution is, or is it overly impacting plan 1 versus plan 4, that kind of thing. Does that make sense?
So today, the option would be to just
No, it was great.
make a, go ahead.
So if my feeling is that we should keep the same rate across all the plans. It's going to be hard enough to sell it to our members. If we're going to say plan 1 is going to cost even more than plan 2, and with all these changes.
With entities too, I thought you're only supposed to go up 3.4%.
Right. So whoever makes the motion, once we get to the discussion piece, I'll just take the recommendations that Ali said. Apply the same rate to all plans, make sure we're clear on that, so it's recorded, and MODA has a directive and providers from us. Thank you.
And then yes, Rick, you could do the math that way.
Thank you. Scott, does that answer your question on the family plan and so to be clear, if we all decide to have the same rates, there's no need for a second meeting because we know the outcome of the final math of the rates and rate scenario, and depends on which scenario we choose the subsidy amount from the reserves, right? Good.
Again, if it's a newbie question, it needs to be redirected. I'm glad to take that redirection. On the slide that has the delta at the very bottom of 18.8% in scenario 1, 17.4% in scenario 2, and such. That delta at the bottom, I heard earlier discussion of those cost increases going up as a result, in some cases, for example, of a provider having, increased capital project costs in their context, or there's a lot of variables that would cause that provider to want to negotiate a higher rate for. And my curiosity is, of that total increase in the resulting delta, is that 100%, is 100% of that delta a function of increased negotiated costs? Or are there other factors that are playing into that?
Let's give Rose a second to switch back to the PowerPoint presentation, Rose. That would be really helpful. Thank you for that.
Some of these are certainly questions I could have asked before our meeting today, but didn't really see the need for that information until now. So I appreciate the patience.
As part of some other work that Mercer recently did, and we did this in partnership with MODA as well, we took overall trend and tried to allocate overall trend into unit cost, utilization, and I think mix was our third one. And of that, we said half of trend was related to unit cost. And so unit cost meaning the providers, what the provider is asking for in reimbursement. So maybe half of trend is related to the cost of services. The other half is related to what services are available and how many members. And then of the cost of services, the provider's overhead expenses, including supply costs and cost of capital, wage costs, cost for technology, all their things play into that as well, as the actual cost of the service.
Maybe you want to go back one slide.
Yeah, Rose, if you would go back, please, one slide to the renewal option scenario slide.
Give me a second. Alex, welcome. We just voted that you're going to cover the gap. Safely. So we have not taken any actions on any plans. Right now, we're just reviewing the amounts and the questions posed of what's the individual cost of deductible, and also the multi-layer, which is the family plan. And the first one that we reviewed was the cardiometabolic program decision, and that decision was not to renew, to discontinue Livongo, but we have not taken formal action on that. When I'll call the question on all the plans at the end of the meeting, you'll see that again, but we are not too far into the agenda. Go ahead.
What other questions on this slide or information do you all need as you think through which scenario to vote for? This pretty much, wraps it up. The remaining slides in these sections just show the individual deductible and out-of-pocket under each of the 5 scenarios. They don't include the family information. We'll definitely bring that next year. It's all summarized here, though, on the renewal options.
I think that last line, can be a little scary, and it's definitely scary, I think, to all of us. But I would say this gives us some time to start working on that number, to bring that number down, to come up with strategies. Some have been bandied about in the last few months. Obviously, we want to do our due diligence over a longer period than that, especially for those that are affected. So I know that last line is a little scary. And it's a projection at this point. It's not something you need to balance to, but it is still a reality as of right now that the board can work from and work to use.
Yeah, I'd say that that last row is really just to help the board understand, to the extent that you use up more subsidy, or less subsidy, you're gonna have a worse renewal next year. So, yeah, it's just context really.
But it's a complicated situation. There's a lot to it. We talked about, can we do plans? We need to start working early on the potentials. Just sets the target of a starting point for a target of what to work towards, starting in May, or no, it is May, starting right after we're done. And yeah, to me, we need to spend more time addressing that than what we typically do.
So if we're doing board discussion on this a little bit, the way I'm reading the last line is if I'm looking at, scenario 2 versus scenario 3, if I go with scenario 2, then we're gonna have to make up an extra 1.3% next year because of the decision. Okay.
Which includes a legislative session to help.
Yeah, well, we can talk legislative session, but the turnaround time to have it ready by this time next year is going to be.
Can be done.
Okay, I'm not gonna rely on it. You can, I'm not gonna rely on it.
I didn't say it will be done. I said it can be done.
Any further discussion on this slide?
Kirsten, what other decisions do we need to vote on? We have the one on Livongo and this one. Are there other votes, other recommendations we need to vote on today?
Yeah, there are a couple. John's gonna walk through. If you guys are done for now, anyway, we can always come back with the medical. Maybe we'll take a break from the medical. John can run you through everything else, dental, vision, lab, and then.
It'd be nice to get an idea of what the full scope of what we're.
Yeah, for sure. There's nothing crazy.
Because if you look at the first line, the efficiency plan changes, that includes the elimination of Livongo.
Right.
Right. I'm just saying, if you vote on that scenario, you are also saying no.
I'm not saying vote on this now. I'm just saying.
I'm just pointing that out, that's built into this chart.
I get it.
Yeah, and of course you can pick and choose from the efficiencies menu, however you like. So, Rose, then if you want to go into section 5, then John can lead you guys through
We
everything.
can do something completely different for a few minutes. Go through the non-medical pieces. Yeah, there we go. And this section, there are two types that we kind of divided it up to make it easier. So there are a couple decisions in the first part, and then there are some things that are informational in the second part. And we're going to cover the ones for the decisions first. And Enrique, I don't know, did you want to make the decisions one by one, or did you want to go through all of the decisions and come back? How do you want to?
So we're gonna. So my understanding from the board earlier was that we're gonna take all the decisions towards the end of the meeting.
Okay.
And then if we have questions.
That works. So, and this is really an expansion of a current program. So the decision here is, the board decision here would be whether to opt into the expansion of this program or not. And this is a program that was first introduced in October of 17. And essentially, as you know, certain drugs are covered through the medical plan, not through the drug plan. And so this addresses those. These are specifically, and it's kind of expanded over time. So it first started with injectable and infused drugs taken at home. So, and essentially, and this is a site of care program. And the thing is that you're trying to encourage people to use the proper site of care or the more cost-effective site of care, which is home in this case. And so essentially, the cost sharing is reduced to nothing for members who do this. And this started in 17 with injectable and infused drugs, and it was expanded in January of 21 to include supportive oncology drugs. And these are drugs that are given to patients to better deal with the consequences of the cancer therapies that, which can be quite brutal. And again, how this works is if you do it through home, it is essentially no cost share to members. And so the question before the board is this new expansion that would move beyond just the supportive oncology drugs to include the therapeutic oncology drugs. And so it's really the same concept. So rather than paying 20% out of pocket, if you have these delivered in your home, it would essentially be no cost share. And again, our thinking, if you want, the Mercer recommendation is really definitely to move forward with. I think that there are advantages, to having some of these things delivered at home anyway. And this is really something that
Did CL made any recommendations on this?
It was not presented to CL. Yeah.
I'm sorry. From the way I understand what you're saying, I guess I would call this an incentive plan. If you choose not to take advantage of it, the benefit remains the same.
Exactly. And if you choose to, your cost sharing is waived. Yeah.
And it also saves the plan some money.
Yeah.
So it's both sides.
It's a win-win.
The patient and the plan saves money.
Right.
Thank you.
Yeah.
Next
one. Okay, so we'll keep moving. So the next one is around, if we go next slide, please. So let me just frame the decision for the board. So there are really three options when it comes to the WDG renewal. One, the first option is, a single year 9.9% increase with no plan changes. The second option is a 3.4 single year increase with the fairly extensive changes shown here. And again, this list is not comprehensive, but it gives you a good feel for the changes. And then the third option is on the right, and essentially this would be in no plan changes, and then you'd be locking in a 3.4% increase, for the next three renewals. So hopefully that.
So when we do the motion is going to be either initial proposal or negotiated option. Do you want to split into?
Well, actually, we can move to the next slide, maybe, Enrique, because then that one just shows you you see here, go ahead.
Is there any rate guarantee for a while after that?
That it, just for those 3 years. So essentially it'd be 3.4% for those 3 years. And, which we think is probably a good deal.
Okay. I'm just wondering, sorry.
Yeah. Back one slide, please, Rose.
Make sure I understand. So the current, under the current column, that's the copay.
Exactly.
And then, so the copay would increase in the right-hand column. And for some of those like really expensive procedures, I know in orthodontics, those members are gonna hit their, like the maximum benefit, right? Probably for some of them.
They'll have an increased likelihood of doing
Yeah.
so, yeah.
Can you remind me what the maximum benefit is?
I'm not sure Willamette has one.
They don't have one. Yeah, it doesn't operate like Delta.
Yeah.
So when just for procedural perspective, so when I call the question or someone makes the motion, I would ask for those who are to vote for option 1, right? Or option 2. And
Yeah, if we could, sorry, one slide down, Rose.
I think you could just ask for Mercer's recommendation.
Okay, if they want to adopt Mercer's, okay, thank you.
So then our recommendation would be, because the thing is, we're concerned of changing the benefits. And so we think, and we're also concerned that you're not increasing 9.9 in 1 year. So we're thinking, the option for locking 3.4 for the next couple of years is better than having a 9.9% increase this year, which would serve, then we'd have to make additional changes on the medical side.
I think this was in response to the board's feedback around, well, 0.0, 0.0, now 9.9. You go back because that doesn't help get to a 3.4%. So that's their response to that.
And I guess I have a question, and for clarity, this new proposal does not have an impact on the options that we were about to discuss, right?
If you go with something that's 3.4, yeah, it won't happen. If you go with the 9.9, it will happen.
Okay, thank you. All right, next.
Okay. And then next slide, please, Rose. So these are just, again, Delta, just a couple of things. One is around cone beam x-rays, which are currently not covered. So the proposal before the board, it would be to expand coverage to include coverage for cone beam x-rays. And again, these are something that are often connected with implants and root canals. And then I'll just kind of go into the Mercer recommendation. I think at this point, given everything else going on this year, we're saying that this is probably best to defer this decision to another year. The second option before the board around dental is the comprehensive cleaning and exams. So this is kind of an interesting one. So currently it's once every 6-month period. And this would be a change to say that it's twice a year. And that might look the same on the cover, but it's not. Because the thing is that you have some people that might, try and schedule their next visit, and it's just in that 6-month period, so they can't, they have to like reschedule it to be further out. It just brings up more flexibility, and I think this is, if I recall, is probably the more standard way for Delta to do this. So I think it would be looking to change. It's a small tweak with a negligible impact. It's bringing more flexibility for members. I think it would improve the member experience. And on that basis, our recommendation would be to move forward with that second option.
The first one is to postpone due to the cost issue, right? And then
Exactly.
The second option is to accept the recommendation from Mercer. Correct.
To accept the change in the definition of, twice per year rather than once every 6 months.
Can you tell us about cone beam x-rays?
I wish I could, but that would be.
Is there a different kind of x-ray that people can get, or is that?
I understand as well.
Dr. Bertello actually isn't available today, but we will follow up in an email and I'll get some additional information from a clinical perspective from her.
Okay.
Yes.
Okay, next slide, please, Rose. So again, this year, no changes were proposed in the vision benefits for, just trying to catch up with my notes here, for Kaiser and Moda. And there was one change that we looked at last month, and then we came back this month, with additional options. And so some of this information is from last month, but we left it in. Again, last month we had just talked about the $15 copay, and then based on the board request, we looked at several other options. And this is really, let me back up and just give you what we're talking about here. So, if you have a very large prescription, you'd have very large glasses, and what high index lenses do is essentially allow you to have a lot thinner lenses. And this is an option that's highly utilized by members, but not currently covered. And so what this option would do would be to provide coverage for high index lenses, which is the number one, as you can see on the slide, the number one selected non-covered lens option. And what this would do would be providing a coverage for that option at $15. And this would have a pretty large impact on, the VSP, and this would be just for the choice plan, the choice plus plan. So hopefully that so what the question before the board is whether or not to introduce coverage for high index lenses as a lens option. And then if we go to the next slide, please, Rose.
Then I have
Yeah,
a follow-up
please.
question. So this new, what is high index lens? Is that more aesthetic? Vision? It is like more aesthetic vision, or it's just like functionally it's gonna
It's
improve?
functionally, yeah, because I have high index lenses. And
Okay.
if my lenses were high index, it would be pretty thick. So
It's not cosmetologic, like,
no,
yeah.
it would be hard on your nose, frankly.
Oh, it's medical necessary then? It's not? No?
No, I don't, I mean, I don't think it's purely cosmetic or purely medical
Okay.
necessary, but I think it's, probably falls somewhere in between there. But I mean, it does make it easier for people. I mean, otherwise you'd be really having to sport much heavier.
What we did for
But if you have the technology.
Well, now we do.
Yeah.
Yeah. Unlike we haven't been doing glasses for 1,000 years.
Right, exactly. Or at least hundreds. Yeah. So again, here we brought the additional options. I think that this was something that you had requested from last meeting. And so we look at a range of options here. The feedback that we got from VSP was, and it does make sense, is not looking at something that goes over $35 on a copay just because it's not bringing that, it's not a good value to the member really at that point. Anything higher than that.
So to clarify, the copays would apply to everyone, not just the high index people, right?
This would just be the people.
Just the high index.
Just the high index people would benefit from this.
So am I right that it's about $60 out of pocket without coverage for the high index lenses?
In the footnote, you're seeing that, Michelle.
Yeah.
Yeah.
On average, you're right. It's on
Sorry.
average, yeah.
I was actually doing the math.
Yeah, but that's good because then the math works out. Yeah. Which is on, that's why above 35, it doesn't make a lot of sense because you're just barely covering half of the cost.
And the rate would go up 3.5%.
At this point, I think it's better to think about it in terms of additional subsidy you'd be spending to make the benefit change. Because that's really I think the practical
That's maybe a
consideration.
little increase in there because that's what it would impact on the overall renewal.
An additional $205,000. Is that right?
Right, for the $35 option.
Yeah.
Well, yeah, sorry. I'm looking at the one that, makes them up the ish. Which is like, why is Mercer not recommending that?
We're not letting money down just because of the challenges, I think, facing this renewal, that it seems like probably something better to reconsider. But definitely, it's something I think we would definitely reconsider in subsequent renewals because as you can see, it's something that's needed just based on how many people are using it. It's not.
Yeah.
But again, that's the board's discretion. That's
Yeah.
just offering a thought.
Yeah. I mean, like if somebody handed me $205,000, I wouldn't think that was negligible. But like in this grand scheme of things, it's such a small amount that it's,
You're in trouble.
It's a messaging.
Sure.
I think we're ready for the next slide, Rose, please. And this is really, we're doing as a package. So there are a fair amount of, as you can see, we've listed all the benefits that are included and the coverages that are included by the standard. And the current plan year is the last year of the current rate guarantee. So that we actually went through a renewal process with the standard this year. And, you know, the outcome was essentially, as you can see here, as an aggregate, in aggregate. So that means across all of the coverages here, a decrease of 4.4%. And that's composed of and then the other thing to note is really also a 4-year rate guarantee. So I think that, you know, these are the two things. And that 4.4% decrease is really, most of the coverages, as you can see listed here, included basic life, employee optional life, child optional life, employer paid LTD, employer paid STD, basic and optional AD&D, were all kind of a rate pass, so there's no change in rates. And then 3 coverages had pretty large reductions, and these included, as you can see, optional life, spouse life, employee paid LTD, and employee paid long-term, short-term disability. So when you look at that package, it's that package of the no increase for most of the coverages, and then these, you know, fairly large decreases for 3 coverages, that results into that 4.4% decrease. So the question before the board is accepting that renewal or not. And our recommendation would be to accept the renewal. Because we had an opportunity to go through it with them. And I know I was going to say that's it, but that is, you know, that is the last of the decision ones. And then we can go through the informational. And again, these inherently don't have a decision with them, and these are contract changes from Kaiser. So if next slide, go down 2 slides, please, Rose. So these are a host of benefit changes, and these are not really optional. These are changes that Kaiser is making, both in terms of medical coverage and dental coverage. So examples include the introduction of cost sharing for allergy serums, adding a benefit for birthing centers, expanding and clarifying the doula coverage. You know, in some districts to adapt to SB 692, and then updating prescription refill limitations. You know, so it's really just, I would say, probably some cleanup things that Kaiser was looking to get straightened out in its evidence of coverages as well. And then, so this is really the ones that impact the medical plans. And then on the next slide are the ones that impact the dental plans. And if we go to the next slide, please, Rose. On the next slide, I'll just say what it is. So in terms of that, you know, there's some pretty specific things around dental emergency coverage that's changing. And, you know, today it's around $100. And then going forward, it will be $100 plus amounts above usual and customary, which is pretty standard practice, you know, that amounts above usual and customary are traditionally not covered. So I think it's really making that clarification.
I have a question, but maybe it's early in the legislative team. I know in the short session, we had a proposal about the IVF that didn't pass, correct?
No.
Okay, did not pass. The reason I'm bringing this up because the members might ask, because our population size and the numbers we serve, if that was to come up next year in the launch session, and I know we had concerns about the cost that could create to the benefits, and we have this sort of situation this year, and like we did last year, will that add a significant problem? Like, will we put ourselves in a, I'm an advocate for IVF and women's rights and all that stuff, but I just want to make sure we clear that. I'm just thinking about these changes and the informational stuff. If it's going to come back again, I feel that we're going to get pushback from the legislator, find a way to fix this and looking at the numbers and the changes. I wonder, Ali, you're working with your team to get prepared to say, is this gonna cost this much to OEB if it is not?
Yeah, we do that, actually. I mean, it's a great point because benefit mandates, we cost them out and we talk to, our agency legislative team, not the position is puts on the 3.4% cap. And for our legislative partners in the room, we've talked about this for years, that any benefit mandates, like you saw a couple on the last slide, that takes up some of that 3.4%, and essentially it takes benefits away, that are outside of the board's discretion. So, yeah, it's a great point.
Yeah, and then last session, they actually exempted OEB and PEB as in an attempt to get it through, because of the cost. And if I remember right, for OEB, it was roughly around 1% added premium to one within that range right there.
When I saw this change in the dental piece and the expansion of doula, which is amazing, it's something that this board should be proud of. Just concerned that they're gonna add something like that without the board, having.
Yeah, it really doesn't even matter whether it's IVF or something completely different. It's just the fact that it's a mandate, that is outside of the board's control when the board is stuck with that 3.4% hard cap, so.
So I guess we had, I have 6 items that we're gonna vote on. Correct? On the slides that we saw. So Rose, I don't know if you could help me with, I guess I can go one slide at a time so we can all discuss and get our eyes, back to the memory where we were. So if you can go back to the first slide, Rose, that talks about the adaptation of the technical word.
Cardiometabolic program.
There you go. Thank you.
That was slide, or page 14, Rose, in the binder, or Mercer slide 14.
And the recommendation is to renew the items that are highlighted and not to discontinue Livongo. So do I have a motion on the floor?
Renew Weight Watchers, Pre-D, Omada Weight Management, Omada Type 2 Diabetes, Virta, and discontinue Livongo programs for the upcoming year.
Yeah, second.
Second.
Thank you. And you like to speak to your motion, Bill?
Sure.
Do you like to speak to your motion?
It's just my work with CIAO and the members, and thanks to the other 2 members that are on the CIAO committee. That was definitely, the data showed that there was an effective program and it was costly, but that wasn't really the point. If it was effective, cost wouldn't matter. It was just not providing reasonable outcomes, and the other programs that will be available were providing effectiveness in their data. Livongo also has some corporate issues. I'll leave it at that.
Discussion.
What was the intended outcome it did not meet?
The member engagement.
The hope was that more members would engage, or that of the 796.
A lot of members engage in that just, they were not.
Continued engagement was a huge issue. That's for all these programs in Livongo was.
We had a similar thing 6 years ago where there was a program that gave you a free pedometer, and everybody would sign up for one session, pedometer, and then there was like 1% after that. Right, it just didn't pay back. But that's not the case here. It's just people are just not seeing the value. They're just not continuing with it.
Further discussion? I'll put the question to you to adopt the cardiometabolic program decisions as presented. All those in favor said aye.
Aye.
All those opposed? All right, motion carries. We have adopted the cardiometabolic program decisions for the 26-27 The next slide I have on my notes, it's the big one. The efficiency, no, sorry, the MODA medical renewal option scenarios. Yes, thank you. Slide 17. So since we have 5 different scenarios, I guess anyone can move a motion on the floor on the scenario that you, or we can do it that way.
I'd like to make a move so we can start a discussion. Yeah. So I will make a motion to approve scenario 2 as presented for the, what's the name of this thing? For the renewal option scenario, for the renewal option for MODA.
And a second. Bonnie, seconds. We like to do your motion.
Yeah, so I know last time we met, I was kind of targeting the 50-50 so that we would have enough money for next year based on the great work from the team as well as our providers to reduce that number down and get the efficiency up to 14 or 15.4. That allows me to take into account some other things about not doing Plan 1. I got the message clear from the other board members that elimination of plans was a bad idea, and I got that message loud and clear from our collaborative supporting members as well. So that brings us into that realm of hearing that very well. And then thus, the second thing is I heard from a number of people that the cost of the problem with giving that high of an out-of-pocket increase to our members really inequitably our lowest paid members, which was a real message that I listened to loud and clear. And with that, I'm willing to say that I take what I was doing last time, which was 50-50, which was a good split for having us in the game next year, to this would be a 2/3. So it's basically 66-33 split on the reserves that we have. So we're still in the game for next year, a little more difficult, it's harder, but it allows the out of pocket to be at 250, which I think is the right for equity for especially covering our lowest paid members. It makes our lives a little harder for next year, but that just means we have to fight harder, and I'm good with that.
Any further discussion?
I'd just like to say a couple of things too. I emailed with a number of folks that in the school districts that I've worked with in the past, and I heard pretty unanimously that number one, we know that Plan 1 is the most popular plan. Most of the subscribers are in Plan 1, and doing away with that would cause real significant problems. And this was making the decision now was considered a very late decision for them to have time to implement that for the October 1st renewal. Also, any of the deductible and out-of-pocket increases greater than the 250 would really be a significant impact as well. There was a lot of concern about that from everybody that I heard from. But I also heard that there was significant interest out there in looking at the plan designs, but that we have to do it. What was suggested to me is that we try to get it done by the end of December 2026, so that we can start getting the word out and involving the stakeholders, so that the word can get out well before that October renewal. And it may not even be October of 27, it might be October of 28 to incorporate whatever they have to in their CBAs. But that we really, it's really come time that MODA takes a look at plan designs and what the offerings are.
Just for clarity, you are for scenario 2, which is the.
I will be voting yes for scenario 2, but I just wanted to make the board know of the feedback that I received.
I can follow on to just what Rick is just sort of saying here, that I really think that the board, even though I'm running scenario 2, which allows us a little bit harder work, that we get started on that right away. And by the end of the year, we have a set from the board or some communication from staff in this board on what's going to happen with plans if the legislation doesn't change. and do that very soon. And by the end of this calendar year was your suggestion,
That was
right?
one suggestion.
And I fully support that we really put a lot of work in the coming months on how to have a communication to our membership and our entities on what will happen unless there's a legislative change, that be our focus, right?
Most school boards are now, or districts are going through negotiations or budget scenarios and getting their budgets in order. So the sooner we can get this to them, better. So I think having it done by the end of the year is an awesome suggestion.
Yeah, it's a heads up that people can say, let's all hope for legislative, action here, but if not, here's your planning document from us. Right.
For a discussion? Oh, sorry, Tom.
I'm sure as for all of you, I'm just so torn, right? Like scenario 2 feels like what's best for our members now, but my biggest hesitation is that we would be making that decision in hopes that there is legislative change. And we have districts all over the state of Oregon, including the district where I'm from, that are facing massive deficits, that are laying off hundreds of staff members, that are closing schools, and our legislators wouldn't even vote to release funds from the reserves to help the schools, right? To help those student-facing employees. And we would be making this decision in hopes that they would agree to give additional funding for wages and benefits. And what kind of look is that if they would do that, but not for our educators, right? On the front lines, we're cutting staff, but we want more money for benefits and wages. So I just have very little faith that they would do the right thing in this scenario, honestly. And again, I don't think it looks great that you would agree to give more funding for benefits and wages, but not for staffing in our schools for kids that are suffering and will suffer next year. It's just a really hard thing for me to have that kind of faith. And I know that we have, including my own union, right? Unions that kind of pushed and advocated for that vote to release the money from the reserves for our school districts. And that did not happen. And I just am really, really concerned that we're just going to be in a worse place next year and it's going to hurt with no help. And I don't know. I'm just saying, I'm just really torn. Like I'm really torn between 2 and 3. One hurts worse now. One could potentially hurt worse later. I just want to let you guys know, like, whatever I end up voting on, like, if this, there's so much caution. That's all. Yeah.
Everything you just said, I'm 100%
Yeah.
on board with you. Michelle, been on,
Sorry,
Yeah.
one sec, Bill, we're going to Michelle.
oh, sorry, did I cut you off?
No.
Right. I'm saying I agree with you, but we're gonna have to get creative. We're gonna have to work hard. We're gonna have to really push it. And I just really want to have our membership just be best right now because we can work it out. I just feel confident that in this team, with Ollie's team, we're gonna find a way, right? And yeah, it's not going to be great. It's not gonna be ideal. It's gonna be hard work, but it's what we're willing to take that on. Sorry.
Thank you, because I want to hear everybody's perspective.
Yeah, I mean, I share your concerns. But I think, the difference between 16.1 and 17.4, like 16.1 is also a crisis. And I keep coming back to this idea that we have in bargaining, when the other side isn't giving you anything, what they're hoping is that you'll negotiate with yourself and bring down the amount of your ask. And I just, and I know that's not an exact, the metaphor doesn't fit like quite well, but I do think there's danger in signaling that we're willing to do that too. So I mean, I'm in favor of scenario 2.
You guys over there. Yeah,
I don't need to repeat the details from the, but I do want to put an exclamation point next to two, sort of to be on the record, sort of some core principles, the idea that, we can come at this from multiple angles and at the same time look at it as a system. It needs a system solution. And I think Rick's early comment about the renewal, paying attention in that space, I think is I would put an exclamation point next to that in rethinking how the system operates. And then I'd put an exclamation point next to the idea that our least advantaged OEB members financially would be seeing a disproportionate impact of the rate increases is really problematic for me. A sliding scale approach in the future would be much more appropriate as it relates to access to healthcare as a right as opposed to a privilege. So that's just the two places I'd want to put a pin in. But otherwise, I support moving forward with scenario 2.
So we have, go ahead, Robert.
I was with Bill last time thinking we needed, in effect, cut it in half so we had 2 years to play with, but that's like scenario 4 and looking at this, it's untenable. Scenario 4, so, I'm leaning towards scenario 3, but I do believe in consensus, so I am willing to move over to scenario 2. I think the impact of that, I don't share, obviously, faith that the legislature is going to, come through for us in the time period we have. I do believe that we have been creative. We have fought hard. I don't know how much more we can do or staff can do, but I'm willing to take that chance. I guess for me, the worst case scenario is that next year, that $250 deductible that we're going to agree to will increase to $500, right? So it's a small gamble. I'm not sure scenario 3 gets us where I want to go anyway, so I'm willing to go scenario 2.
Yeah, had 4 speakers in favor and 2 who are. Oh, sorry. Go ahead, Misty. Maybe.
I support scenario 2. I think that coming into the legislative session by dipping into our contingencies and signaling to the legislators that we might be functioning with a bit of an antiquated model concerning the cap of 3.4% and taking a look at that and trying to keep our, the cost to our members down as low as we tangibly can, but still sit on some reserve for next year. So scenario 2 for me.
No further discussion.
I would just say I appreciate all the feedback and the input for our November retreat. I think we could be prepared to provide some of the information that we're talking about as far as plan designs. I think, hopefully before that in October, we could come back with a financial update and really look at our claims again. They're going the right direction, but, we hope that trend continues. But yeah, I think for November, we already do the renewal so early that that's a little bit scary, but I think given the collective bargaining agreements and the requirements of our partners, something we should do.
I don't have to vote on the tiebreaker. I just do want to acknowledge everybody's concerns and thoughts on scenario 2 and 3. For my members, I will definitely hear either way, no matter what we pick, they're going to be upset, right? But I'm concerned about next year. At the national level, we have elections, November. Inflation is going to continue to increase, and we still have a war in Iran. Who knows what's going to be next year? I think the economy is not really working for the working class, for any of us in this room, because we're all part of it. I'm just concerned, fearful that Robert, we're gambling, and obviously no one knows the future, but I'm concerned that we're going to have to pay more next year. because we're trying to soften this year, and I just want to put it in the room and Morgan's here and COSA and OSBA and OSEA and everybody, but maybe in the retreat, we can all have a longer retreat and talk about how we can strategize with our organizations on the legislative session. And there's no appetite from leadership, from my perspective, on fixing the revenue problem in Oregon. I think we all can see that. I think we're gonna have to be working closely, because I just don't have a good feeling for next year. I'm trying to be positive, but that's just the reality. So that's all I put in the room.
Big state election too, not just national, but we had a
State, but yes, of course, yes.
No, I mean, yeah, I agree that the faith is not there in everything that's going on. But I will say, I know that we can't undo what is done, right? So if we increase those deductibles by 500, they're never going back down.
So what I would, so what I'm hearing and been keeping track, I hear 4 people in favor and 2 on not supportive or not knowing. So I'll put the question to all of you, and then if further discussion, you can always ask to reconsider after we finish all those votes. So I'll put the question to you for the model medical renewal options scenarios. The OEBB board adopts scenario 2 of the subsidy of $64 million, $15.7 million for the RSR for MODA, and the OSF $48.3 million. It's an estimated 27-20 increase subsidy base of 17.4%. Deductible of $100, correct? Like, all those in favor, raise your hand. Motion carries. So we have adopted scenario 2, and hold on, sorry. I know 250 deductible, sorry, 250. So correction on that, 250. But also I want to ask, do we need to note it that the MODA, the board wishes to have MODA have the same percentage for the OEBB programs?
Yeah, that's.
Okay, so you'll add that to your motion, Bill, and then
yeah, so for staff to apply the rate increase equally across the plans. Should we re-vote on that?
Yeah, we should vote on that.
Amending my motion. Forgot about that, sorry. So revote.
you revote on that scenario 2 with adding that MODA will
Equally divide the increase across all plans.
all those in favor, raise your hand. All right, thank you. Motion carries. And I guess my ask to Ali, and I know he does this all the time, but I think all of us will be talking points on how we proceeded with this decision and what's the outcome. Because as you pointed out, the bargaining contracts and that are coming into play. All right, so that's our second motion of today. The third motion, I'm sorry, third motion, yes, is the opt-in Oregon MODA medical. That's the second, sorry. The third motion is the dental renewal. Sorry, I am right. The next motion is the Mercer recommendation to opt into the program medical changes side of care expansion.
That's slide 24.
I make a motion that we accept Mercer's recommendation on the side care expansion.
Second.
Thank you. Would you like to speak to your motion?
No.
All right. Any further discussion? All right, I'll put the question to you to adopt the recommendation of opt-in program for medical changes, side of care expansion. All those, please raise your hand. All right, motion carries. The next motion, motion 3, Dental, you'll increase, WGG, Mercer recommendation is at 3.4% for the next 3 years, so we'll have discussion on that since we have multiple options to vote on.
Rose, slide 26.
I'll make a motion so we can discuss it. I'll move that we accept option 3, the Mercer recommendation of a 3-year, 3.4% guarantee.
I'll second that motion.
That's it to your motion.
I think that it makes sense for us to lock in the 3.4. We certainly can't go with the 9%. And I think locking in the rate is a good idea.
I'll concur with it. Locking in 3.4 makes it predictable for the next 3 years, and that's something we need a little bit of, even though it's small, but still a little bit of that is good.
Further discussion? All right, all those in favor to adopt the Willamette Dental Group 2026 renewal option 3 with a 3.4, no changes at 3.4, a 3-year locked in of 3.4%. All those in favor, please raise your hand. All right, motion carries. We have adopted the Willamette Dental Group 2026 renewal option. The next option is Delta Dental or Oregon 2026. So there's one part which is
Slide 27, please, Rose.
that is that the Covine X-rays are not covered. The Mercer recommends to postpone option 1. So I'm happy to take a motion to discuss option 1.
I make a motion that we accept Mercer's recommendation to postpone the providing for the cone beam X-rays.
Second.
Would you like to speak to your motion, Rob?
No.
I have a question.
Yes.
Okay, so I just want to understand like what the member experience is. If they need an implant or root canal and the dentist says, well, you have to get this cone beam X-ray, but you have to pay for it. Or do they say like, you like this cone beam isn't covered, but this other option is, and you can still get your root canal or your implant. Does that make sense? Like,
But we need this.
I know, well, I just,
Answer a
Yeah.
little bit, and I'm so sorry, I wish Dr. Berkler were on to be able to answer more thoroughly, but the scenario, the member experience would be the same. To me. So cone beam therapy or cone beam X-rays are offered today, but dentists will, or dental providers will always look at what we call benefit tracker. That's where they can get in and see exactly what this member's benefits are. So they're either not going to even offer it to the member, or they might say it's available, but it's not covered by your insurance, and then let the member decide.
but they still can get the implant or the root canal.
Yes,
Okay.
it wouldn't impact them being able to
Got it.
access it.
Okay, any questions? Sorry, it took me a while.
I just have a technical question for Mercer. What's the difference between postpone and reject?
I think it's, if you want to bring it up.
So it's just a note to staff saying we
Exactly.
want to revisit.
Exactly, it's the revisit.
But it's kind of a reject right now.
Reject for now, but revisit.
Okay. Thank
Here's a question to you to option 1. Mercer's recommendation to postpone the Covine X-rays are not covered. Declare this is just a postponement that could be brought up to consideration in future years. All those in favor, please raise your hand. Right, motion carries. Option 2 for the Delta Dental of Oregon MODA 2026 renewal options. Mercer recommends to accept the comprehensive exams, cleanings, and this removes barriers in care by allowing members to collect with scheduling medical care. Do I have a motion on the floor? Please.
Option 2, the Mercer.
Second.
Go ahead. Would you like to stick to your motion? So I'll put the question to you to adopt Mercer's recommendation to accept option 2, which is periodic or comprehensive exams, cleanings, periodical maintenance, and fluoride and recover once in any 6-month period, exempts cleanings. This removes barriers from for members getting care. All those in favor, please raise your hand. Thank you. Motion passes. And the next one is the vision benefits and changes in options.
Rose says slide 29. Thank you.
This is the vision benefit changes and options. And there's, the option is 0, which is recommended by Mercer. If you want to discuss the following options, feel free to make a motion.
I'll make a motion to postpone this.
If you have a second.
I like it.
I'll second the postponement.
Like to speak to your motion.
I love the idea of this added benefit for sure. In a year, that's not like that.
Is there further discussion? All right, I'll put the question to you. All those in favor to adopt the postponement of BSP Choice Plus 2026 benefit options? All those in favor, please raise your hand. All right, thank you. Postpone the BSP Choice Plus plan 2026. And then the last one is the standard life disability renewal of 4.4 decrease.
Thanks, Rose.
Thank you. And the information merchants to renew.
I make a motion that we renew the standards life and disability plan as presented.
Second that.
All right, to speak to your motion, Bill.
All good.
Any further discussion? All right, all those in favor to adopt the standard life and disability insurance, please raise your hand for renewal. All right, thank you. Motion carries. You have renewed the standard life and disability insurance for 4.4 decrease with 4-year rate guarantee of coverages. And that's it.
Hey, Enrique,
Yes.
can I just double check? So embedded in, we didn't explicitly vote on the efficiency packages, so I just want to make sure the board understands that as a part of approving scenario 2, they are also approving the efficiency package. Just want to make sure everybody's all
I
clear.
thought we did. I will made the motion on the efficiency package, didn't I? Oh, no, the cardio.
Not on the realignment of the copays, that's part of that, yeah. So
I guess
we do need-
scenario 2, you know.
No, I'm
that
with you.
efficiency package.
Yeah, it has it in there.
Yeah, I just want to make
Yeah,
sure
it's in
it's
there.
clear that.
I think I mentioned that during our debate that
Earlier,
it
yeah.
included the efficiency plan changes.
Yeah. I understood.
All right, Ali.
I just want to thank everyone. Incredible work today. Really hard work. We will have communications materials out for you next month to look at, and hopefully have something before that. We should have final rates within a week. Since we're applying that increase equally, there's no need to set up a separate board meeting to vote on numbers. So if you're all right with that, I think good.
All right. Safe travels to all of you. Make sure you get home safely. Let us know if you need a ride or.
I got a car.
Um,
They loaned me one.
any other questions for the good order? Misty, see you. All right. Well, we're done. Thank you. Yeah. Thank you.
Thanks.
Sure.